Okay, very good. So let me introduce Jacob. Jacob Reinkemeyer is a baseball player here at McKendree. He's my mentor as well. I had him in kinesiology, and so he decided to continue with his study that he started in kines, and his study is the eccentric and concentric strength-related injuries in baseball players. We thank Jacob for providing this presentation, and let's get started.
Hi, everybody. So like Dawn just said, I am doing a presentation which builds upon my last paper in kinesiology. So when I was trying to figure out what I wanted to do, she and I had a conversation sort of about like what I wanted to do with my life, and it ended up in terms of baseball again, because I've been in baseball all my life. And we ended up with talking about this eccentric and concentric strength concept. But I had already done the maximal external rotation of the shoulder. So I wanted to stay in line with that and do these injuries related to pitchers in the form of shoulder injuries. So with that, I will go ahead and start this. So for my presentation, I have a few objectives. There's 3 questions that I would love if we were all able to answer at the end of this. The first, what are the key conditions leading to injuries? The second, what can I do to prevent these injuries? And the third, what rehabilitation methods can I use to be both preventative and reactive? I feel as if these 3 questions encompass my whole goal of this conversation and this paper. So with those objectives in mind, what did I find? I found that there are several conditions indicative of shoulder injury, all of which are related to eccentric and concentric strength of muscles within the shoulder. I found that there are many ways to combat these injuries, both preventative and reactive, all associated with rehabilitation. Some of the main themes were that overcompensation or imbalance, can be both good and bad. This was a very interesting concept to think about holistically. I also learned about glenohumeral internal rotation deficit. I'm not going to say that the entire time, so I'll be saying Gerd for the sake of how big that phrase is. And I also learned a lot about scapular dyskinesis. So the methodology for this paper that I have done, it is a retrospective study. I derived information all from databases like Google Scholar or EBSCOhost or PsycInfo. I was also able to get my hands on a textbook called Therapeutic Exercise for Musculoskeletal Injuries by Peggy Hoglum, and all of these were scholarly articles and were very, very helpful for me during this time. So with that, I'm going to go ahead and bring us to the first theme of this presentation, which is talking about overcompensation. So what is it, right? It's pretty self-explanatory, I think. To put it in very layman's terms, one part of the body takes over for a part which is lacking sufficient strength to do a movement or do an activity. I have some examples of this. First and foremost is sort of a tight chest. So when you have a tight chest, those pectoral muscles are constricted, and in turn that brings your shoulders forward, which rounds your shoulders, and you can see it in this picture. This lady has her shoulders brought very far forward, and you can even see that her scapulas are kind of rounding around her rib cage. Another example is limited elbow extension. I actually dealt with this myself because I had surgery last year in February. I had Tommy John surgery, not that fun. Basically what happens is when the elbow cannot fully extend or fully straighten, your shoulder compensates and finishes the reaching motion that your elbow cannot do. Another one sort of looks at the body holistically in terms of the kinematic chain, which is basically just how the body reacts from bottom to top and from top to bottom. So an ankle injury can cause a whole funk of a mess for a baseball player. For example, if a pitcher were to sprain their ankle, let's say their left ankle for the sake of a right-handed pitcher, they go to land on that left ankle and it can't bear all of the weight. So what happens? The knee takes some of the weight, which then messes up the hips, which then messes up the shoulders, and in turn messes up the arm. So overcompensation can lead to a lot of poor mechanics and can really subject an athlete to more injury. So what's the cost of this imbalance? That's the biggest question I think that that overcompensation needs to have answered. It's all about perspective. In my introduction, when I was going over the themes, I mentioned that it can be good and bad, and that comes from variability in performance. So to put that in perspective, I'll use myself as an example again. My variability in performance it stems from my velocity in pitching. So on any given pitch, I have the ability to throw a fastball at 80 miles an hour as well as 87 miles an hour. So that range and variability is created by the imbalances in my body. When you get to higher level athletes like Jacob deGrom, for example, who is currently with the Mets, a starting pitcher, his variability in performance is anywhere from 98 miles an hour to 101, even 102 miles an hour for his fastball. So the specificity there, which is my next point, is very good for him. I have another example of this. So person A and person B are both an athlete and a non-athlete, respectively. So person A will attribute them to a baseball player. In this example, they both present total range of motion for the shoulder, which is 180 degrees. However, person A is displaying more degrees of external rotation, less degrees of internal rotation. In a typical non-athlete, that ratio between internal and external rotation will represent more of a 1-to-1 ratio. So closer to the 90 degrees of external rotation and internal rotation. This is a very, very specific example of specificity because it is representative of most overhead athletes because of the constant motion that they're having to go through. Like with a pitcher, they bring their arm forward, so the lack of mobility comes here, and the more mobility is in this position. I can't do it right now because when you have that specificity, there is an obvious change in tissue behavior. So when I was talking about the tight chest example, when you go to use your chest muscles, other muscles in surrounding structures will take over because of the anatomical change in your body, because of the way that it is built now. In terms of pitching, you have your decelerators all on the backside of your dominant arm. These are all more subject to eccentric contraction because of the specificity and the change in structure. The bottom line of overcompensation and imbalance is that skill development will always have a cost every single time, and that cost is almost always longevity. So we see this with the past 10 years of baseball. Pitchers have been throwing harder and harder and harder. I think it's been an increase of pitching velocity of about 4 miles an hour over a decade. Conversely, those pitchers are throwing less pitches per game, simply because the vicious movement of the pitching motion takes a toll on the body. And when you have high specificity, that can decrease the overall health of the body in the long term, although it is helpful in the short term. So next, moving on from overcompensation, I'm going to talk a little bit about Gerd. What is it, right? That is always the question. Gerd is an adaptive process in which the throwing shoulder experiences loss of internal rotation. This is a very sport-specific adaptation, specifically to overhead athletes. Why does it happen? There are three main reasons that you will see Gerd. The first is contracture of the posterior capsule, which is just the back of your shoulder. When you mobilize the back of your shoulder, you typically will get external rotation gains. When you get those external rotation gains, something has to give, which is typically the internal rotation of the shoulder. Next are bony adaptations of the shoulder. These are very common. These are common enough to often be talked about. An example would be bone spurs in overhead athletes. They can happen anywhere. They can happen in your elbow. They can happen in your shoulder. They can happen in your wrist. When they happen in your shoulder, the impingement or the pain that you'll experience will make you want to move your arm less. The third reason it happens is all about hypertrophy. So the external rotators, which is again just the back of your shoulder, those will increase in size and increase in tightness, all due to the frequent eccentric loading of the constant motions of throwing. So Gerd is always associated with slap tears, rotator cuff tears, internal impingement syndrome, all of which have to deal with the glenohumeral capsule, which is your shoulder capsule. The stability is very, very important. The overall health of the shoulder musculature is super dependent on passive and active restraints, as well as the dynamic stability of the eccentric and concentric contracting muscles. That is a mouthful. These surrounding structures, ligaments, and the joint capsule all have to work together and are interdependent on one another to maintain the overall health of the shoulder. So why is this significant? Why do we care about Gerd? During a throw, your rotator cuff muscles concentrically contract and then eccentrically lengthen while in order to decelerate the arm, to keep it in, basically to keep your shoulder in its socket. This is very, very important because if it comes out of its socket, that'll tear ligaments, it'll tear muscles, and it'll be very, very hard to come back from in the future. So you have to have adequate strength in your eccentric and concentric musculature in order to prevent and promote health of the shoulder. So a diagnosis for Gerd would look something like the picture I had of that specificity of the external and internal rotation of the shoulders. However, it is an assessment of the total range of motion. So if one shoulder represents 180 degrees of total range of motion and the other shoulder represents more than a 10-degree difference, so let's say 168 degrees of total range of motion, that shoulder with the less total range of motion would be attributed to Gerd. Next, we have scapular dyskinesis. So what is it? Again, the most important question. Scapular dyskinesis is any deviation in the normal movement of the scapula during shoulder movement. So I have an example here, and you can see in these pictures that the lady in question is raising her arm above her head, which is totally normal shoulder movement. But what you see differently is this part, which is her scapula, is coming out and wrapping around her rib cage, which is not what you want. You can see in her left shoulder, it wings out and moves up, which is the wanted motion of the scapula. You can even see in her resting position that the scapula is more winged out and wrapped around her rib cage, which is not good. Scapular dyskinesis is associated with several things. First is the increased scapular protraction. So that stems from it wanting to wrap around the rib cage. You're going to want to be protracted, which just means pushed forward. Serratus anterior lower trapezius weakness, all dysfunction related to the anatomy of that scapula. Upper trapezius hyperactivity, so you're gonna feel more dominance in your trap, and altered scapular rotational timing, which has to do a lot with baseball. So in baseball terms, scapular dyskinesis presents as diminished external rotation in the late cocking phase. And I have a little picture there so we all know what the late cocking phase is. It's basically when the pitcher experiences the most layback of their arm when their stride foot has hit the ground. In this instance, there is a high chance of compensation, which it's back again. The exceedance of muscle tolerance leads to compensation in order to manage the excess load. This is a very important aspect of the entire presentation because the exceedance of muscle tolerance is the initial reason for compensation, which is the initial reason for a change in anatomy and a change in muscle load, which would in turn be the reason for injury. With this compensation, there is a real-time difference, right? You can see a decrease in velocity and an increase in impingement. Oftentimes, an impingement will represent in the AC joint, which is the acromiocoracoid connection, I believe. Acromioclavicular, that's what it is. So we know what these are, right? How can we stop that? How can we be competitive? The biggest and likely most important thing that I have seen through all of this research is the concept of sport-specific lifting. So what is it, right? Sport-specific lifting is a way of simulating movement or exercise in the weight room, which is similar and applicable to actions of the playing field. So this has absolutely taken everything by storm, and organizations have come together and have been created. Dryline Baseball for one, Premier Pitching and Performance for another. These organizations have dedicated years of research to creating programs that are tailored to specific athletes so they can be strong and be healthy on the field of play. It is the main reason for an increase in velocity in the Major League Baseball organization. Professional athletes obviously have the best or the most access to the best resources. So it's totally reasonable that the trend in increase in velocity is going to just continue to skyrocket. More than strength, though. Sport-specific lifting is also all about recovery and how you warm up. So some athletes may need to work on hip mobility, and in their specific program, they can be assigned mobility drills in order to loosen up those joints and those ligaments. In terms of baseball, you'll see a pre-throwing routine, which will look like Jaeger bands or throwing driveline balls. For recovery, you'll see Jaeger bands, you'll see waiter walks, you'll see the use of a body blade. All of these things, which are very subjective, are very specific to the individual. Another main thing that I saw was the acute to chronic workload ratio, and this was really cool. So the basic idea of this is it is the ratio between acute and chronic training loads, which is acute basically is analogous to the state of fitness and chronic is analogous to a state of fatigue. In acute training, it would be more of a day-to-day, whereas chronic training would be more of weeks on end. this was created to help with the maintenance of sport-specific lifting, as well as throwing programs. So with Driveline Baseball and Premier Pitching and Performance, those organizations have dedicated people that manage this ACWR. When it was implemented, there was an increase in recovery, an increase in overall performance, and an increase in overall health. The goal of this is to not add stress. It's to enhance your recovery, which is a very, very big part. You have to be able to know what workload you are working toward. It regulates your throwing and your lifting to achieve the ideal individual workload. And that's the thing, is that it's totally individualized. My workload could be completely different from Jack's workload or what have you. Loads too high or too low increase your risk of injury. And there has been proven reduced injury prevalence and improved overall performance with the admittance of this concept. So why is this applicable? What are my conclusions? What are my takeaways? This whole paper and this whole presentation mainly applies to pitchers. However, it deals with realistically all overhead sports because of the sport-specific lifting techniques, because of the rehabilitation techniques, because of the similarities in movements between the sports. So I have volleyball, you in a spike, you see same sort of arm motion as you see in pitching, and in tennis, you see similarities as well. This PowerPoint really went over some generalized rehabilitation measures, with the sport-specific lifting and the implementation of the acute to chronic workload ratio. And even more so, it can help you save money because it's preventative of injury. And we all know hospital bills can be quite expensive. So with that, I would love to open up the floor and answer any questions anyone has. Feel free to unmute yourself or do whatever you need to do. And we'll wait just a couple minutes.